Great. So once again, it's another health weekend talk show, and I am your host, Dr. Albesedo here. I do this every week because I notice, and we all will agree that there's a lot of misinformation on social media, especially from people who are not experts in the field. And I do this as my way of contributing to help reduce the level of misinformation out there and to give accurate medical info to people so that you can make informed decisions. That's the essence why I do this. I do this to help people, especially those who are looking for a quick fix for things that will need some time. All right, when you hear from the expert, you get better understanding. And today, this afternoon, we are pleased, of course, this afternoon, this morning, or this evening, based on when you are watching this video, we are pleased to have a specialist medical doctor. She is the first female to be hosted on the Weekend Health Talk. Yes, yes. She is a specialist hematologist working at Kolebu Teaching Hospital Sickle Cell Clinic. She has a special interest in sickle cell disease, and she's here today to tell us more about sickle cell disease, all that we need to know about it. But before she starts, please join me welcome Dr. Ivy Murray Agri. I hope I got the name Ivy Murray Agri. Before she comes on to start, please put something in the chat box to show that you're welcome here. Just welcome her with some emoji. Welcome her with some emoji. I know you can't clap or you can't talk, so put something in the chat box to welcome her so that she knows she's welcome to present to us. Before you start, Doc, before you start sharing your slide, please tell us why your interest in sickle cell disease. Over to you, Dr. Ivy.
Okay, hello everyone. I hope everyone can hear me. Good afternoon, good morning, good evening, and welcome to all of you to today's program. So as Dr. Sidohia said, I'm so grateful for this opportunity. Thank you for having me. It's a pleasure. It's exciting to know that I'm the first woman to be on this program. So as he said, I'm a hematologist. By God's grace, I just passed my membership exam. So yes, I'm a hematologist now. So I'm into hematology because as a medical officer, I was posted to the sickle cell clinic. And before I even got there, like in growing up and in school, you always hear that people who have sickle cell disease don't live long. By 18 years, they have died and all that. So it was very interesting for me to go to like a clinic that's especially dedicated to people living with sickle cell disease and see like very old people, 40s, 50s, even 70s. And it's a joy to know that there's so many advancements in managing sickle cell disease now. Like there's hope. Sickle cell disease is no longer a death sentence. So that just piqued my interest in sickle cell disease. And then I went on to do hematology. And then, yeah, so now I'm a hematologist with interest in sickle cell disease. Yes. I think you're muted, Dr. Sidohia.
Okay, please, over to you. Share with us what you have for us, please. Over to you.
Sure. Okay, so I hope everyone can see my slides.
Yes.
Fantastic. So we will begin. So I'm going to give just a brief overview of sickle cell disease. I'm going to try and make it very simple for everybody to understand. So yes, as said, my name is Dr. Ivy Murray Agri. I work with the Department of Hematology and the Sickle Cell Clinic at Kolebu Teaching Hospital. So this is going to be the outline of the presentation. Okay, so sickle cell disease is basically a condition that affects the cells in the blood called the red blood cells. So in your blood, there's actually three main blood cells. You have your red blood cells, which carry oxygen. So there's a protein in your red blood cells called hemoglobin, and this carries oxygen to the various organs in the body. And then you also, in blood, you also have white blood cells, which help you to fight infections. And then you have platelets. And what the platelets do is that they prevent you from bleeding excessively when you have a cut. But then sickle cell disease affects mainly the red blood cells. And even the red blood cells, they affect mainly the hemoglobin. Now, it results from the presence of we call in science, we say mutation, but it's basically an alteration of the form of hemoglobin. Every adult should have normal hemoglobin, which is hemoglobin A. But in sickle cell disease, there's a problem in the formation of that hemoglobin. So then you form hemoglobin S. And for somebody to be defined or said to have sickle cell disease, they have to have two abnormal genotypes. So they have to have one sickle gene and then another hemoglobin variant. So apart from the hemoglobin S, there are other hemoglobin variants. So they are all altered or mutated forms of hemoglobin. We have hemoglobin C, we have beta thalassemia, we have D, we have F. So then you see that some people who have sickle cell disease will tell you they are SS. Some people too will say that they are SC. All of them are like different hemoglobin variants. But to say that you have sickle cell disease, you have to have two abnormal hemoglobin genes, such that if you are somebody who is AS, you don't have sickle cell disease. You have the trait, or you can carry it on to your children, but you don't have the disease. Okay, so worldwide, about 300,000 babies are born with sickle cell disease, and majority of these are in sub-Saharan Africa. And then in Ghana, you can see the red is basically where sickle cell disease is more prevalent, and you can see that is in sub-Saharan Africa. And then in Ghana, about 15 to 30% of people have the sickle cell trait. So we usually say 1 in 4 people have the sickle cell traits, and then 2% of babies born annually in Ghana have sickle cell disease. So it's a big deal in Ghana. Now, it is a lifelong condition that people are born with. So you cannot acquire sickle cell disease. Somebody cannot infect you with sickle cell disease. And if a person gets the sickle gene from both parents, then they have the SS that I talked about. If I'll show a diagram to explain all these things that I am saying. But then if a person gets the sickle cell gene from one parent and another abnormal gene from another parent, they will also have sickle cell disease. So example, SC, maybe they get one S from one parent and a C from another parent. It's still sickle cell disease, but they have SC. Or they get an S from one parent and a D from another parent. They'll have SD. Now, if the person gets the sickle gene from only one parent and the other parent brings a normal gene, then they have the sickle cell trait, which is AS. So this is just a picture to explain so in this SC sickle cell, N is normal and T is trait. So as you can see, if a father has the trait and the mother is normal, then 50% of their children will have their traits, 50% of them will be normal. If both parents have their traits, then 25% of the 25%. Sorry, it's in every pregnancy. In every pregnancy, there's a 25% chance of a child having sickle cell disease, a 50% chance of a child having the traits, and then 25% of a child being born with normal hemoglobins. Then if one parent has sickle cell disease and one parent is normal, then there's 100% chance that all the children will have the traits. Then if one parent has sickle cell disease and one parent has their traits, then for every pregnancy, there's a 50% chance that the children will have sickle cell disease and 50% chance that the children will have the traits. If both parents have sickle cell disease, then for every pregnancy, there's 100% chance that all their children will have sickle cell disease. And it's important to know that this inheritance is for every pregnancy. So it's not that if you have 4 children and then you both have their traits, then your first child will have their traits, your second child will have their traits, your third child will have sickle cell, your last child won't have sickle cell. No, for every pregnancy. So if you have 4 children, then there's a probability that all 4 children will have sickle cell disease. Again, there's a probability that all 4 children will have their traits. So it is for every pregnancy, you have these probabilities. So for the mechanism of sickle cell disease, the normal red blood cells, the ones that have the hemoglobin A, they are disc shaped. So like this, or like basically like a donut. They are flexible enough to fit through the small blood vessels. But then in sickle cell disease, because of the abnormal hemoglobin, the red cells tend to have an abnormal or sickle shape. So a sickle is something that is usually used to harvest rice. It's like a farming instrument. So then it looks like this, or you can call it a banana or a crescent shape. So the abnormality of this cell and because of the altered hemoglobin, these cells tend to be very sticky and they tend to be very hard. So unlike the donut-shaped or disc-shaped normal red blood cells, these sickle cells, they are unable to they are unable to bend or fit through small blood vessels. They are not flexible enough to fit through small blood vessels. So they get stuck and then they block the flow of blood and oxygen to the organs in the body. Now, when this happens, they don't bring enough oxygen to the organs and the tissues in the body. So they cause pain and then eventually organ damage. The thing about the red blood cells that are sickled is that they are, because of the way they are shaped and because of their abnormality, they are broken. Your normal red blood cells usually last for about 120 days in the body, but these sickled red blood cells last between 10 to 20 days in the body. So then there's a constant shortage of red blood cells in the blood of people who live with sickle cell disease. So this is a diagram that just shows how the normal red blood cells look. As you can see, it's normal red blood cells that flow through the body. Nothing blood to various tissues and organs. So the symptoms usually start after the baby is a few months old. Most commonly, people with sickle cell disease have episodes of pain. As I explained earlier, it's because enough oxygen is not reaching the tissues and the organs. So they have episodes of pain. And then sickle cell pain, it can be anywhere. It can be in the bones, it can be in the chest, it can be in the abdomen, it can be in any parts of the body. And it can be mild or severe and last hours to days. Some people have pain that within 2 hours, the pain is gone. Some people can have pain that is persistent over a whole week. And then usually the first presentation of sickle cell we see is something we call dactylitis, which is basically swelling of the hands and feet of babies. So for most children who are not tested in infancy or at newborn screening, that's the first presentation that their parents see, that they have pains in the hands and the feet. And then when you see that, you begin to suspect, along with other things, if the child might probably have sickle cell disease. So as they grow up, they still have pain. Some of them can have pain in their chest with trouble breathing. They can have fever. They can have cough. They can have pain in the bones. And usually, what all these pain episodes I'm describing, we call it sickle cell pain crisis or vaso-occlusive crisis, because usually it's due to the occlusion of the vessels. Most of the episodes of pain, they cannot be predicted, but sometimes it is related to certain triggers. And there's like a little diagram of the triggers here. So we have dehydration, we have infection. So you know that if you know anybody who lives with sickle cell disease or you have a health worker, you know that we encourage people who live with sickle cell disease to drink water a lot. It's because dehydration can cause them or precipitate pain crisis. And because we live in a very tropical country, like it tends to be very hot sometimes. So we encourage them that they should drink water at least 3 liters a day. And then infections can also precipitate pain crisis. So infection prevention is very important for people living with sickle cell disease. Stress, emotional stress, physical stress, all of it can precipitate pain crisis. Then weather changes. Either when it is very hot or when it is very cold, it can precipitate pain crisis. Most of us know when it is very cold, so they shouldn't play in the rain. They should always have their sweaters when it is cold. But rise in temperatures can also precipitate pain crisis. And then exhaustion, when they're exhausted too, it can precipitate pain crisis. then it can, apart from the pain, so pain crisis, the number one presentation of people living with sickle cell disease. But apart from the pain crisis, they can also have other symptoms and problems. So include severe anemia. Now, anemia is basically when there's a drop in your hemoglobin concentration in your blood. And we already talked about the fact that the sickled blood is broken down very, very fast. So there's a shortage of red blood cells. Once there's a shortage of that, we know that the hemoglobin protein is in the red blood cells. So when there's a shortage of that, it means there's a shortage of your hemoglobin too. So then they have the things that can show that somebody has anemia is that they are easily tired. If it's children, they don't feed as well as they usually do. They have what we call reduced exercise tolerance, so they are not able to play as much as other children their age are able to play. Some of the people who present with anemia are dizzy. They have what we call palpitations. They have like very, very fast heart rate. You have increased breathing. Some people have headache. And then another thing is they can present with very severe infections, which can be recurrent chest infections, so a cough and difficulty breathing and fever. Then they can have
All right, so I think Dr. Ivy has an issue with her internet. She'll get back to us shortly. Yeah, Dr. Ivy has a small issue with her internet. She'll get back to us shortly. I'm trying to get her back shortly. So let's just stick and stay. I'm getting her back. She's back. She's back with us. It's her internet. All right.
Okay, sorry. I think I went off, but
Yes.
yes, sorry. I'm sharing now.
Okay, please continue.
Sorry. Let me share my screen again. Okay, so I was talking about the other symptoms of sickle cell disease or other presentations of sickle cell disease. And I was talking about the stroke. So they can present with a stroke. So in adults, all the signs that we know of a stroke, weakness, headaches and all. But then for children, it's important to know that sometimes children have what we call silent cerebral infarct, or basically brain infarct. So they don't do well in school. Like maybe they were doing really well in school and suddenly they don't do well in school. It's not because maybe they are suddenly not smart, but sometimes it's like they're having little strokes in the brain. So that's something to look out for. Then we have avascular necrosis, which is basically a distraction of the bone, the head of the bone. Is usually the thigh bone and then the shoulder bone. So usually there's, because again, the sickle cells are not supplying the organs and the tissue and the bone. There's distraction of the head of those bones. And then there's priapism, which is basically unwanted, painful, sustained erection, like erection for males. And that's also another presentation of sickle cell disease. Okay, so then in addition to all these other things that are suggestive somebody having, you should suspect that somebody has sickle cell diseases. If there's a family history of sickle cell disease and somebody has recurrent episodes of pain or recurrent pain crisis, it's important that person is suspected to have sickle cell disease, or there's a history of sudden death in a young child. Maybe the child was never tested for sickle cell disease, but there's a history that there was sudden death. Then frequent bone pain, as I mentioned earlier, frequent chest infections, as I mentioned earlier. Then even when there's a failure to gain weight despite good nutrition, so you are really feeding the child well, the child is eating well, has no problem with meals, but then the child is just not gaining weight. If you look at the child compared to other children their age, or even sometimes compared to their siblings, they appear smaller. There's something that we call small for age. It happens with people with sickle cell disease. And then persistent jaundice. So maybe that you've noticed yellowing of the eyes of somebody you know, or like a relative, and like you've done everything, it has been treated for an infection. There are other causes of jaundice, but then after all those things, the jaundice still remains. It could be that the person has hemolysis from sickle cell disease, so he or she has to report to a hospital to be tested. And then I already mentioned that the dactylitis is also called hand and foot syndrome. Then there's also what we call frontal bossing. So in this picture, you can see that the forehead of the child is big. This can be a presentation of sickle cell disease, but then in some families, they have big foreheads. So you can't go pointing to everybody who has this, that they have sickle cell disease. Sometimes it means sickle cell disease. Sometimes it's just familial. So like all these are important. And then we have what you call natopathy as well, which is basically, it's like the teeth can't fit into the mouth. Like that's the only description that I can give of it. Okay, so because blood goes everywhere in your body, it means that the complications that we can get from sickle cell is from head to toe. Okay, so for every system in the body can be affected by sickle cell disease. And initially, when somebody with sickle cell disease is growing up, the fear is, oh, will they live? Will they live? But as they grow up, now the fear is of them getting complications because of the sickle cell disease. Because as we know, repeated episodes of oxygen not getting into your tissues or into your organs will damage those organs. So I already talked about the stroke that can affect your brain. Infections like meningitis can affect your brain. The eyes can be affected as well. There can be blindness in the eye. There can be the lung. I talked about lung problems. Apart from infections, there can be pulmonary hypertension in the lungs. Then we can have the liver can be affected. You can have gallstones from the repeated hemolysis. Some of the breakdown of the hemolysis products can crystallize and form gallstones, so they will have abdominal pain. Then we have something called, I didn't mention it, but then we have something called asplenia or autosplenectomy in people living with sickle cell disease, where it's like basically it's like their spleen has disappeared, but it's because the repeated sickling caused the spleen to shrink. And then your spleen is responsible for filtering your red blood cells, but is also responsible for fighting certain infections. So that's the reason why people with sickle cell disease tend to have recurrent chest infections, because some of the bacteria that cause those chest infections, some of them, there's no spleen working well enough to fight those infections, so they keep getting the repeated chest infections. For the people who still have their spleen, there's a problem of sometimes the spleen becoming bigger than normal because all the blood pulls up into the spleen. Then for women who become pregnant, they can have complications of pregnancy, both to them and to their baby, because of sickle cell disease. So to their baby, sometimes you can have what we call intrauterine growth restriction. So their babies don't grow to the full weight that you expect. For the women, they can have preeclampsia, they can have preterm labor and complications due to pregnancy. Then I talked about they can have renal damage as well for people living with sickle cell disease. They can have, I already talked about priapism, but they can have delayed puberty, such that for females or women, girls, their menarche can be maybe at 17 or 18 for people living with sickle cell disease. I mentioned the avascular necrosis. They can also have infection of the bone itself, which we call osteomyelitis. Then they can get recurrent skin ulcers, and usually these ulcers are at the ankle joints, around the ankle joints, and then they can be recurrent, so they will heal and then they'll come back, and then they'll heal and they'll come back. And it's all because of the complications of the sickle cell disease itself, apart from the fact that the vessels are being occluded. Hemolysis too can lead to a worsening ulcer. And these are not ulcers that when you give antibiotics, the ulcers will be treated or healed. These are not infective ulcers. They are venous ulcers. So they keep like recurring and keep recurring and keep recurring. Then there's also the matter of chronic pain. So apart from the acute pain crisis, some of them have this chronic pain that is like constantly there's pain. And then there's nothing you can, the most that is done is that you can give maybe analgesia for it, but it's pain that is there all the time. So, and these are the complications of sickle cell disease. I'm sure there's even some more that I haven't mentioned, but this is just a brief overview of the complications that can be associated with sickle cell disease. Okay, so in diagnosing sickle cell disease, you can do a blood test. A blood test is what we use to diagnose sickle cell disease. And usually in some hospitals in Ghana now, we do what we call newborn screening. It's usually in the teaching hospitals. Outside the country, in most hospitals, they do newborn screening, not only for sickle cell disease, but for other genetic conditions as well. We are trying to make newborn screening more routine. And in newborn screening, you can see whether your child has sickle cell disease from when the child is born. If that is not done, and the child grows up, then you can do what we call a sickling screen. You know that before they enter school, some schools do like a full medical exam. Even university are expected to do a full medical exam, and usually they'll do a sickling screen. Now, the thing with the sickling screen is that it tests for only the presence of S. So once you have the S, then they'll say you're sickling positive. So if you're sickling positive, it doesn't mean you have sickle cell disease. It just means you have S. So you can be AS and be sickling positive. What will tell you whether you have sickle cell disease, whether you're AS or SS, is the HB electrophoresis, which I've put there. And that will tell you whether you are AS or another thing. The thing with the sickling screen is that it means if you are AC, the sickling screen won't pick it up. If you are CC, it won't pick it up. So we won't know. So somebody can think that the sickling screen will just report AC as sickling negative. So the person will assume that they are AA, and then maybe have a partner who is AS, and then have a child who is SC and wouldn't understand how they have a child with SC. But it's because the sickling solubility test just picks the S. So if there's a C, it won't pick that as well. So now the recommendation is that if you do a sickling screen, do a HB electrophoresis to pick exactly what genotype you are, so that if you are AA, you know. If you are AC, you know. If you are AS, you know. And that informs the decisions that you take. Another test that is done, all of these are blood tests, is the HPLC. And what this does is that it quantifies the hemoglobin that you have. So if you are really SS, it quantifies the amount of S that you have. If you are SC, it quantifies the amount that you have. And these help in some of the therapies that we give sickle cell, because we look at how well we use this quantification to look at how well the drug that we are giving is doing. The diagnosis of sickle cell can also be done way before the baby is born. So we have what is called chorionic villus sampling, which basically samples a part of the placenta, and that's in the first trimester. Or we can do amniocentesis in the second trimester. This one, the amniocentesis samples a part of the fluid around the baby. So if you are there are two people who are AS, and then you get pregnant and you want to know before the baby is born to make arrangements, you can actually do some diagnostic tests before the baby is born. Unfortunately, I don't know if any facility in Ghana offers these tests right now, but in developed countries, they do. So for the management of sickle cell disease, there's supportive and specific management. So the supportive ones, I put number 1, routine reviews at the clinic, okay? It's important that anybody you know, or you yourself, if you have sickle cell disease, you are enrolled in a sickle cell clinic, okay? Whether you are unwell, whether you are well, it's good that you go routinely to the clinic, because it's important to know your baseline labs and how well you are doing on some of the drugs that you are on. Then some of the complications, they don't show up overtly. So I mentioned renal impairments. Now, the renal disease doesn't suddenly show up like one day you show up to the clinic and suddenly your kidneys are not working. It starts with something very small, a very small amount of protein in your urine that routinely you might not pick up if you do the routine labs. But if you go to maybe a sickle cell clinic, they can do those small tests for you to see, so that if there's some renal impairments that we can see, then something can be done about it then. If you go routinely to for review at the clinic to redo, so at the sickle cell clinic at Kolebu, we advise that you go for yearly ophthalmology eye checkups to check to see if your eye is being impaired. We do scans to see if there are any gallstones, how your liver is doing. There are certain labs that we do routinely to check, because it's not all the complications that manifest overtly at first. Some of them start from change in your labs, and that is how we use to see if there's any problem and intervene early. Then hydration is important. I already mentioned why hydration is important, because as your red blood cells are breaking down quickly, some of the substances that they are releasing, they are toxic to the tissues in and of themselves. So you need to hydrate to wash them away quickly. Then folic acid, and we already mentioned that dehydration can lead to crisis. So you need to hydrate adequately. Hydrate with water, not like just juice and all those things. Yes, water is important. Then folic acid and multivitamins, and these are all supposed to help to make new red blood cells, because we mentioned that your red blood cells are breaking down quickly. You have shortened amount of red blood cell lifespan. It's decreasing the number of red cells that you have. So we want to make new red cells quickly. So folic acid and multivitamins will help. Then vaccinations. I mentioned how some people don't have, the spleen is not working at all because repeated sickling has caused it to shrink and it's not working as effectively as it should. So the vaccinations will help you to protect you from the organisms that your spleen is no longer able to do. Then analgesics for pain relief. So if you are somebody living with sickle cell disease, or you know somebody living with sickle cell disease and they have pain crisis at home, you can give like some analgesics, like immediately they have the pain, to relieve their pain. Most of the people who live with sickle cell disease know what works for them. So they can tell you that, oh, me when I take para 2, it works for me. Me when I can take maybe tramadol, just one, it will work for me. Or me, nothing works for me. I need to go to the hospital and need to be hydrated if I'm in this amount of pain. It's important to listen to them. Then if this also is supportive treatment because it doesn't treat it, but if their blood, as I mentioned, they have severe anemia, then you have to give them blood. And usually when we are giving them blood, we give blood that has no sickle cell in it, so that it will reduce the amount of hemoglobin S in their blood. Then I mentioned infection prevention. So they sleep in a mosquito treated net, and they take care of themselves. When they buy fruits and vegetables, they wash it well, all these to prevent them from getting recurrent infection. And rest is very, very important. Rest is important. We know that physical and emotional stress can precipitate crisis, and then good nutrition as well. Then for the specific management, I've divided it into two. So disease modifying therapy, which is, so for some people, chronic blood transfusions modify the disease. So they don't sickle as much if every month they are getting a blood transfusion. Now, usually this is for a select group of people. So either you've had a stroke before, and then for children, there's a scan that we can do on their brains to see if they have a probability of getting a stroke. If we find that out, we can recommend chronic blood transfusions. And that has been found. Studies have shown that prevents them from getting the stroke in the first place. Now, if they do get the stroke, then they have a high likelihood of getting a second stroke. So again, chronic blood transfusions can be recommended. And now what this means is that maybe every month they'll be coming for blood transfusion to reduce the amount of sickled red blood cells in their blood. A drug that is currently on the Ghanaian market is hydroxyurea. I've learned recently, so even on insurance now. And what it does is basically the same thing that the transfusions does. It prevents your red cells from sickling. It increases a certain hemoglobin called hemoglobin F, which is basically childhood hemoglobin. Now, this is protective. It doesn't let your red blood cells sickle. So it's protective, and it's been found to reduce the pain crisis. It's been found to reduce the need for hospital admissions as well. Then there are other drugs. There's crizanlizumab, there's voxelotor, there's L-glutamine. All these drugs, they modify the disease. So they prevent the cells from sickling in the first place. So it's not like the supportive therapy where now it has happened, so now you need to manage it. No, this prevents the crisis in the first place. Then last thing for the specific management is curative. So what this seems to do is to cure the sickle cell once and for all. So you have bone marrow or stem cell transplant and then gene therapy. At a point in time, I think Rich Hospital used to do bone marrow transplants. I don't think they do that anymore, or they have stopped for a while. And what basically happens here is that we are clearing. So the bone marrow is where all your cells are produced. So if somebody has sickle cell disease or is living with sickle cell disease and undergoes a bone marrow transplant, we are clearing all their cells and giving them the cells of somebody who doesn't have sickle cell disease, so that the new cells that they will produce won't have the gene. And then gene therapy is basically the same thing, but this one is you are giving the person sort of a trick to the body to not for their body not to make those altered hemoglobins again, to make normal hemoglobin. Gene therapy is still being explored. Is nothing. We don't have anything definitive as at yes, but bone marrow transplant is offered to people in certain countries, especially those with severe disease. Okay, so basically the take-home message of this presentation is that sickle cell disease is an inherited condition. You don't acquire, nobody gives anybody sickle cell, and it affects the red blood cells and then causes them to change shape and then block the blood vessels. And it is inherited in the same way that you get your eye color, and you get your skin, and you get your hair. A blood test can be done to determine your sickling status. And as people living with sickle cell disease, they now live long because there are many advancements in care. So it's important that you get tested. If you haven't been tested yet, you know your genotype, and then you make an informed decision, especially for those who are considering marriage with partners like who are AS and AS. Yes. So if you haven't been tested yet, if you haven't learned anything from this presentation, if you haven't been tested yet, I think you should be tested and know your sickling status. I know my sickling status. Do you know yours? Thank you very much. Over to you.
Welcome, Dr. Ivy. We appreciate that. Was a great presentation. A lot of take-home messages, a lot of information, of course, coming from someone who is on the field doing the right things. Thank you very much. Now, we have a few minutes to ask questions, so please feel free, put it in the comment section, put it in the chat box, ask any question at all that you have concerning the presentation that Dr. Ivy just gave us. Please ask your questions quickly. Ask your questions in the chat box and let her answer us quickly. We appreciate you, Dr. Ivy, for such a thorough presentation. I enjoyed it, and I have been informed and updated on what I knew earlier. My take home is, if you do sickling tests and it is negative, it doesn't mean you are safe. You could be AC, you could be CC, and then you go have somebody with AS, and then the child has SC. Thank you very much, Dr. Ivy, for that great information. Yes, so all of us need to do the HB electrophoresis. Thank you very much. If you have any questions, please, either on Zoom or on YouTube, please feel free to put in a chat box, and then we'll ask Dr. Ivy to give us the answers. So I'm monitoring those on YouTube and those on Zoom. Please feel free, put your questions in the chat box. And if you are watching this video after this live presentation and you still have questions, you feel free, put it in the chat box on YouTube, and we will respond to you very, very swiftly. Yes, after this presentation, the recording will be available on my YouTube channel. All right. Okay, so now a question is, how does fetal hemoglobin work?
Okay, so the fetal hemoglobin, what it does is that it holds on to your oxygen longer than, so because the sickle cells, they are sickled, they are not able to hold on to the oxygen for a very long time, but fetal hemoglobin holds on to oxygen a little longer. Now you see that I mentioned that in children, like they present with dactylitis and things. That's when you first see that they have sickle cell disease. Now the usual presentation of this is when they are like maybe between 8 months to about a year. And that's because they at that point in time, they have a high amount of fetal hemoglobin. But gradually, as they grow up, the fetal hemoglobin reduces till they are supposed to have normal hemoglobin, which is why they then begin to present. So what the fetal hemoglobin does is it prevents so I mentioned that some people have F as an abnormal persistence, hereditary persistence of fetal hemoglobin as an abnormal hemoglobin variant. So we have people with sickle cell disease who are sort of like SF, but then they don't present as remarkably as people who are SS or SC because their fetal hemoglobin is protective for them. So they don't sickle as much. Yeah, for them.
All right, thank you very much. Somebody is asking, elaborate a little more on the vaccination aspect of the management.
Okay, so for everybody who has sickle cell disease, every child who has sickle cell disease should have all their like childhood immunization vaccinations. But then there's a pneumococcal vaccination is important. Okay, I forgot to mention this as well. So pneumococcal vaccination is important because usually that is what causes the chest infections. And we know that the spleen usually helps to fight like the encapsulated organisms like the pneumococcus. Now, as they grow up, some people recommend that they get another pneumococcal vaccine like later on in life, which is sort of protective. And then I forgot to mention that for children up to about 5 years, it's recommended that they be on penicillin prophylaxis. And this is also supposed to do like fight and help prevent infection against pneumococcus. Yes. So
Right,
they are supposed to get the normal, like, yes, they should get the normal immunizations as well. But then the pneumococcal vaccines, it's important.
All right,
Yes,
somebody is
please.
asking, how many types of sickle cell do we have?
When you say types, I'm guessing you mean like SCSS. Is that it?
Yeah, I'm sure that's what
So
people
that
mean.
one, we have plenty. So we have the ones we usually know are SS, we know SC, there's S beta thalassemia, there's S with persistence of hereditary persistence of fetal hemoglobin, there's SD, there's so many. Once there's S and another abnormal hemoglobin, then it's sickle cell disease. So there's many.
Thank you very much.
Yes.
Somebody wants to know, does the frequency of crisis depend on the level of S?
I no, it does not. It does not. It does not. Because so that's the thing. Everybody expresses the sickle cell disease differently. So you might even have somebody who is SS who doesn't get crisis as much as somebody who is SC. It depends on the person. The phenotypic expression of it is very different. So it depends on the individual. So it doesn't the S percentage doesn't really determine it. But usually people who are SS are the ones who get the more frequent crisis, are the ones who need the more frequent transfusion of blood. Yes.
Okay, somebody is saying a patient was put on hydroxyurea, but the patient felt more sick. In this case, what will you advise?
Okay. So there are certain parameters that will monitor you on when you're on hydroxyurea. It's not everybody who responds to hydroxyurea, which is why it's great that there are all these options now, and all these options work in different ways. So some people, you notice that even when they're on hydroxyurea, they still have the crisis. The frequency doesn't stop. Then for them, we'll probably put them off hydroxyurea and recommend another disease modifying therapy. So we monitor you on the hydroxyurea. It's not like once everybody should be on it. No, we monitor you on the hydroxy. We monitor your labs. We monitor your clinical response itself to the hydroxyurea. So if a person is not responding to it, then we'll probably change the therapy or stop it. Yes.
Somebody is asking, can I get more information on CC?
So technically CC isn't hemoglobin, like it's not a sickle cell disease, because if we all remember, the definition means that there has to be a hemoglobin S, and CC is 2 hemoglobin Cs. Okay, but then in people that in CC, they've been noted to have hemolysis, so the breakdown of red blood cells is seen, but it's a very mild disease. Their life expectancy is like those of normal population. They don't usually have the pain crisis that people with sickle cell disease have.
All right. Another person wants to know, can someone with sickle cell take any kind of blood tonic?
So usually we advise that people with sickle cell disease don't take blood tonic because, and like, so iron blood tonic, because when the blood cells are breaking down, the iron is not being, the iron is not going away. The iron stays in the body and is being used by the body. So the more iron you take, it means the more iron you are taking into your body, which is not being lost. Like, we know that hemolysis, in the breakdown of red blood cells, for health workers here, you know that in the breakdown of red blood cells, the iron still stays in the body and is used. It's used for other things. So the more iron you take, the more iron that you are storing in your body. The body has a difficult way of getting rid of iron. So we don't recommend that you take iron routinely unless you've gone to a hospital and iron like therapy has been recommended for you, which is why I specifically mentioned only folic acid and multivitamins and didn't add iron to it. Because even when they have anemia, unless they have iron, we have proven that it is iron deficient anemia. We usually maybe transfuse blood instead. Okay, and then give maybe folic acid and then multivitamins. And we should know that with people with sickle cell disease, if you know somebody who is living with sickle cell disease, or yeah, somebody who is living with sickle cell disease, especially in your SS and your HB is 7, it is not strange because for most of them, that is what their body has learned to live with, the 7. So at 7, they are very capable of performing all their activities. We shouldn't think that because we know that HB below, hemoglobin below maybe 10 is very severe, then it means for them, we have to give them iron or give them blood. So we need to know, like, if you are somebody living with sickle cell disease on this call, it's important to know your stable hemoglobin. So that when you go to the hospital and you're unwell, you tell them that, oh, my hemoglobin is 7, so that you're not transfused aiming to get to 10. Because the 10 might never be reached, or if it's reached, it means now your blood has become even more viscous, and that can precipitate you to more crisis.
All right, someone else want to ask, after 5 years, are we to stop the penicillin V by what you said, or there's a criteria?
Ideally, so for the studies that I have seen, usually I think it's up to 5 years. I know some people who are way older who still take penicillin V. I haven't read much on the effects it has at that age, but the effect is usually seen like up to 5 years.
All right. Somebody is, do we have the advancement of the care for sickle cell disease patient available in Ghana?
Okay, so currently hydroxyurea is available. It's available even on insurance now. And then I put another drug, the crizanlizumab. We are doing we started like a trial of it at the sickle cell clinic Akolibu. So like, and I know Child Health has another drug. I've forgotten the name, that like they are piloting to see how like Ghanaian children will respond to. So we haven't made all the progress yet, but like there's some work being done on like sickle cell disease, like advancements of care in Ghana. Yes, and I mentioned that the fact that at first, I think Rich Hospital was doing bone marrow transplants for sickle cell disease. I think there's a pause on it now, but as you can see, like everybody is trying to chip into advanced care of people living with sickle cell disease in Ghana. Yeah.
All right, thank you. Does Kolebu do bone marrow transplant, please?
No, please, we don't.
Currently not. Okay, all right, thank you very much. Any more questions? We have a few seconds to go. Very few minutes to go. Thank you very much. Any more questions? Put in the chat box on YouTube or on Zoom. I'll read it out for our specialist to share with us. Very key, something she said, which I'll reiterate in a few seconds whilst I'm closing. Very, very key. A lot of people make that mistake, and I'll reiterate it. All right. Anybody has any more questions? Any more questions you have, please put it up so that we get properly educated. All of us, even doctors, if that is not your field, you are limited in the knowledge. So we are all learning. I see doctors, surgeons, I see specialists on the call, and everybody is on the call till now learning. So well done to every one of us. Somebody is recommending good eating habits and taking enough water and your multivitamin. Great. That is very good. Exactly what the doctor said. Any more questions? All right. Now, in the absence of any further questions, like the question that was asked about the need for if the person can take just any blood tonic, she said they only recommend folic acid and multivitamin because the blood tonic have iron, and the body finds it very difficult to eliminate iron. So the advice for you is folic acid and multivitamin. Not to overload the system with too much iron, resulting in something else. Am I right, Dr. Ivy?
Yes, please, you are. You are.
Great. So people need to know that the fact that a person has anemia, who is a sickle cell disease patient, doesn't mean you should go and buy just any blood tonic to overload the person. You might end up causing more damage than the good you intend to do. Any more questions? All right. So now, okay, good. So there's a question about supplementation. In my own experience, let me just see if I can pull up something. Dr. Ivy, with your permission. So she recommends highly multivitamins, and there is one on the market that I know of, Enfuse, which has vitamins and minerals, very good. It supplies all your vitamins that your system needs on daily basis. Yes, a little expensive, true. It's one sachet daily. So yes, even children and adults can take it. It provides the vitamins that is recommended globally for people living with sickle cell disease. And people living with sickle cell disease are also known to have very low glutathione levels naturally, and their immunity some way somehow is also very low. So for children, I will recommend Max 1, which will help them. And for adults, they can take Cellgivity. So best among them for sickle cell disease patient, Max Enfuse. Max Enfuse. Okay, somebody is sharing testimony. Susan says, my niece is on Max 1 and Enfuse, and over 3 years now, she's doing very good. Yes. So this is what I know. Thank you very much, Isabel, for sharing that experience. People with sickle cell disease have naturally low glutathione levels. These are not curative. They are supportive. All right. The vitamins and Max 1, very good for kids. A little expensive, but when you get it, it will reduce the frequency and severity of the crisis. So yes, there is a role of optimizing glutathione levels in the body to help manage the sickle cell disease. All right. So there are two key things that I'm going to reiterate from Dr. Ivy's presentation. The first one is the fact that your sickle cell test came out negative doesn't mean you are okay. That's number one, because you could have CC, you could have AC that was not picked on the sickle cell test. You need to do HB electrophoresis, which will tell you the genotype. The second one is sickle cell disease patients mostly have low HB level, low hemoglobin levels. It doesn't necessarily mean they need blood transfusion. Their body has adjusted to low levels such as 7 or 8. However, if the blood level is even low and they need something like to boost up their blood levels, giving them just any blood tonic does not help, because you might end up overloading their system with iron, which the body finds a bit difficult to eliminate. So what it's recommended is multivitamins and folic acid. Allow the body itself to produce its own red blood cells, because overloading the system with too much iron will not help. And if you ask for any recommendation, there's been a testimony in the chat box. Isabel, thank you for sharing. She has somebody who is SS, and she's recommended Enfuse and Max 1, and it is helping the person, because truly low glutathione levels have been found out in people living with sickle cell disease. Thank you very much. Thank you very much. If you have any more questions and you're watching this on YouTube, you can drop it in the chat box if you're watching this later on. And okay, somebody has a question. Let me just find out if that can be done quickly. On YouTube, I have somebody with a question. Can one take a break from hydroxyurea? The patient is 9 years. Dr. Ivy.
No, please. You can't take a break. You can't take a break. Sorry.
All right. So you have to take the hydroxyurea for a very long time. All right. Thank you very much for that. Any final words, Dr. Ivy?
So yes, basically, if you don't know your sickle cell status, I think somebody asked what to do when somebody with SS is pregnant. You have to go and see, like, you go to a high risk, because somebody who has sickle cell disease is a high risk pregnancy. There's a sickle cell clinic for pregnant women at Kolebu Teaching Hospital that I know of. I don't know. I think we are piloting it in other hospitals as well. But then basically go to a high-risk pregnancy, go to like a clinic, an antenatal clinic where they see high-risk pregnancies. But basically my take-home message today is if you are not tested, if you haven't been tested yet, go and get tested and know your sickle cell status. It's amazing that you called me to do this because September is Sickle Cell Awareness Month. So yes, it's important that we know about sickle cell disease. Yes. And then for those living with sickle cell disease, we are making so much progress and so much progress in managing sickle cell disease. So the future is bright.
All right. Thank you very much, Dr. Ivy, for such a wonderful presentation. Yes, September is Sickle Cell Awareness Month, and we are blessed to have our very first female specialist on the call to share with us about sickle cell. And we've all been informed, including myself and every one of us. Thank you very much. Yeah, yes. Okay, so thank you very much. Someone is asking me privately about what I was recommending. Yes, so what I was saying is that it's highly recommended that people living with sickle cell disease, it is known from the research, okay, PubMed.gov, that people living with sickle cell have low levels of glutathione. So optimizing their glutathione levels will optimize their health in general, boost their immunity, and help them have less frequent crisis, and even the severity will be much less. So yes, practically, I have personally recommended to people, and good to know that Suzanne has also recommended to her own niece the combination of Max 1 and Enfuse. Now, Enfuse is the blend of nutrients. We need the vitamins for these sickle cell patients. They need it. They need the trace element. They need it for their development. They need it for their well-being as well. So yes, if you're able to combine the Max 1 and the Enfuse, if they are children or adults, very good recommendation for them. Thank you very much. At this point, I guess there are no more questions. So I just want to again say thank you very much. Please help me say thank you to Dr. Ivy. Put in the chat box, say thank you, Dr. Ivy. Let's appreciate her for her sacrifice. You can tell she was from a car. She went for a program and she made time to come out and honor this presentation. Please put in the chat box. Let's appreciate Dr. Ivy, our very first female specialist presenter, and she's very fresh as a qualified specialist hematologist. Dr. Ivy, we appreciate you. Thank you very much for the time, the sacrifice. Thank you very much. Thank you very much. Thank you very much.
Thank you too. Thank you for having me.
All right. Okay, somebody is also asking, yes, last minute question before you get off. When somebody stops hydroxyurea for a period and resumes, what happens?
Stopped for how long? And why did they stop? And why did they stop? So once you stop, your cells go back to how they were pre-hydroxyurea. So then we need to know why they stopped. Was it because, so like as for any drug, hydroxyurea has side effects. So was it because of the side effects? It's important to get better context of why they stopped. But if it's just stopping, then your cells will go back to how they were before. They will continue to sickle, you continue to have the pain, all those things. Yeah.
All right. So it's not advisable for you to stop the hydroxyurea once you start. So thank you very much. So those with sickle cell disease, please, the advice is eat well, drink lots of water, and the kids should sleep under insecticide-treated mosquito nets. Live healthy. Make sure you are registered to a sickle cell clinic. Dr. Ivy made that one very clear. Make sure you are registered to a sickle cell clinic where you go for regular reviews, whether you are well or unwell. And there are routine annual checkups that you do, including eye care. Just because you have sickle cell, they want to be sure you're not having complications with your eye and other parts of your body. So it's very important. You have sickle cell disease, that's you have S and something else, you need to be registered, enrolled into sickle cell disease clinic. It's very, very important. And if you want something that will optimize your health, I will recommend Max 1 and Enfuse to you. Thank you very much for your questions. If you have any questions, you want to personally contact me or any help, this is my contact. Feel free to reach out on WhatsApp or on call. I prefer WhatsApp mostly, though, anytime, and we will be glad to help you. Thank you very much. Thank you very much. Thank you very much. Again, next week, we'll be live with another specialist. Thank you very much. Once again, it's been a plum, pleasing pleasure serving you all. Let's all enjoy our